Thank you to my long-lasting strabological friend Rosario for this global introduction that touched me deeply. I guess you have sent spies in my private life to find all these details. And yes, although this is a virtual conference, we are still human with real lives. I would like to thank the board of ESA and especially John Sloper for the invitation to give this lecture. It is an honor for me to be here. Nevertheless, the situation is a bit disappointing, and I surely would have preferred to see you all in Paris and enjoy togetherness. The topic of my lecture is the role of Vergence Tonus in esotropia and the possible consequences on their surgical treatments. I would like to dedicate this lecture to my main mentors, who were Professor Maurice Quéré and Dr. Annette Spillman. Both had a very clear way to analyze, examine, explain, and treat esotropia. And I would like to dedicate it also to Arthur Jampolsky and his impressive open mind. I know he was aware of the surgical consequences of tonus in esotropia. Annette Spillman underlined the importance to take into account the clinical signs of dystonia in esotropia and introduced the translucent occluders to ease examination of dystonia. Professor Quéré insisted on the importance to search for signs of dystonia. He constantly opposed peripheral and central clinical signs when he examined esotropias. He underlined that systematic bimedial recti recession based on preoperative measures could lead to unexpected early or late results because it did not take into account the innervational part of the deviation. Then I had the chance to participate to those symposia organized by the School of Nantes. There, the young French-speaking strabismologists that we were could talk freely with more experienced one, and of course we have been replaced now by a much more brilliant and younger generation. And I would like to thank Alain Péchereau, who always had a friendly and critical look on my works as for the works of my French colleagues. He may be proud to have been at the origin of a generation of French strabismologists now gathering in AFSOP. I first worked on pediatric ophthalmology and especially infantile cataracts, lens implantation, cure of difficult cases of amblyopia, and as many, I moved to this fascinating subspecialty that is strabismology. It became rapidly my main field of work and interest. I was amazed from the start that the same surgical treatment was proposed in two different situations as shown on these two almost identical esotropia that become totally different under anesthesia. I worked on the path of my mentors, and I am going to expose the results of my humble works to try to explain and solve this situation. Part of them have been published, but all of them have been presented in ESA, ISA, or APOS congresses. Esotropias are defined as a convergence of visual axis, whatever the primitive mechanism. Maddox's model of vergence is still the best way to analyze vergences, even if it simplifies too much some complex and intricate mechanisms. The rest position of the eyes is generally in slight exoposition. It is accepted that it may be observed under deep general anesthesia, and it may be estimated behind double translucent occluders. In awake but non-fixating patients, tonic vergence straighten partially the visual axis. This dissociated position may be approached with a unilateral cover test. If the patient fixates at distant fusion locks the visual axis and avoid diplopia. Two main mechanisms help to fixate binocularly in the proximal world. There are proximal vergence and accommodative vergence through the ACA ratio. Of course, we state in this modeling that the patient is emetropic or wearing its full ametropia correction. And fusion, once again, helps to lock binocularity in near vision. We may explain all the types of strabismus with two types of anomalies. The first one is anatomic and is responsible for an abnormal rest position compensated or not by vergences. The other mechanism is neurological or innervational. It is the dystonia that may affect the tonic vergence, the near vision complex, and of course, fusion. In the first course of esotropia, there is a priori no reason for the rest position to be abnormal, except in rare cases. Esotropia is purely related to the dystonia with muscle overaction. If esotropia is long-lasting, the permanent situation of convergence progressively may induce shrinking of medial recti and stretching of lateral recti, and then a modification of the rest position. Esotropia becomes fixed, whatever the state of the dystonia. We know that non-treated ametropia may induce abnormal stimulation of accommodative convergence and provoke or worsen a strabismus. Tonic vergence is known to be very strong in infancy and to decrease with age. This may explain that at least 20% of infantile esotropia disappear spontaneously before age 3 years. It may also explain the rate of at least 25% of consecutive exotropia after surgery of esotropia in children. Proximal vergence may also modify with time. Ideally, the treatment of esotropia should use specific means for each possible cause. There is always a fusion failure in esotropia. When binocularity is normal, fusion is restored with prisms or surgery. But in infantile esotropia, fusion is absent or very poor. Searching for ametropia and prescribing its perfect optical correction is the first, the easiest, the safest, and mandatory treatment in esotropia. Then we know that esotropia that persists afterward is related with other mechanisms that may be dystonia and an anomaly of the rest position. The dystonia leads to overactive muscle, and this overaction may considerably vary with time and usually decreases. The abnormal rest position is related to the progressive adaptation of muscles. It usually, but not always, gradually becomes the predominant anomaly in long-lasting strabismus. It is logically treated by recess-resect surgery, but the majority of surgeons perform this type of surgery to treat both dystonia and abnormal rest position. The results are indeed satisfying in the early postoperative period, but actually long-term results are not so good, with at least 25% of consecutive exotropia that are not so easy to treat and probably related with the decrease of the dystonia with age. To solve this, it has been proposed to differentiate muscles and tonus treatment. The first obstacle is to differentiate what is related to muscles and to tonus. And as you see, it is the examination of the strabismus under anesthesia that may differentiate the two situations as dystonia disappear and, on the contrary, to anomaly of the rest position. But there are also some clinical tips to identify dystonia. Annette Spielman showed very nicely how to evaluate clinically the possible relaxation of esotropia observed behind double translucent occluder that you can also observe here. The relaxing esotropia may be also observed by glaring with a torchlight. And at last, it may be spontaneously observed from an exam to another with time. The main lesson I learned from Professor Kéré was the importance of the examination of strabismus under anesthesia, with two main points that are the position of eyes under anesthesia and the evaluation of the tightness of muscles. Under anesthesia, tonus disappears and the eyes are in their rest position. The difference between the awaken and the rest position could be called the rest incommittancy, what Kéré called the sign of anesthesia. On these pictures, you can see two totally different situations, with on the left an angle that is similar under anesthesia and on clinical examination, with no rest incommittancy, and on the right, a total relaxation and then a large rest incommittancy. You can, to be reliable, the evaluation of the strabismus under anesthesia must be performed under deep general anesthesia. It has an accuracy around 5 prism diopters, just as Hirschberg's method. Some computerized photographic methods are in progress, such as the Strabocheck software. It is known that there is a systematic exoshift under general anesthesia, underlining the role of tonus in almost all types of strabismus. Finally, the examination of the strabismus under anesthesia leads to a new classification. Esotropia remaining unchanged under anesthesia are purely anatomic esotropia. They are related to a modification of the rest position, therefore to muscles. On the opposite, esotropia that vanishes under anesthesia are purely tonic esotropia. They are related only with the dystonia. The medial recti are overactive but normal. And finally, the most frequent situation is esotropia that vanish partially, related to mixed mechanism of dystonia and muscular changes. Force duction tests are known, specially used in pulses and fibrosis by example. We can see here a tight medial rectus, but without quantitative data. The conclusion is that the muscle is too tight and surgery should be performed on it. Works have been done to try to quantify this elongation, even if it is still imperfect. The method that I show you has been developed in France by André Roth and Alain Péchereau. It uses a caliper and a hook with a dynamometer tuned on 50 grams when you pull it fully. You position the eye so that the corneal reflex is centered and place the zero of the caliper facing the reflex. Then you pull the muscle fully and measure where the muscle's insertion can go on the caliper. Here the muscle doesn't reach the center and stops at -3, meaning a tight muscle. And here the muscle goes beyond the zero to +3, meaning a soft muscle. Normal values for horizontal muscles have been published between minus and +2 millimeters. Duction tests give indication about the state of elasticity of the muscle and its implication in the possible rest position. Elongation measurements help to tune surgery of recessed resection. Tight muscle may be recessed, and personally I follow exactly the lack of elongation, just as it is performed on fibrosis in grave ophthalmopathy by example. And I carefully tune the resections to the amount of elasticity of the muscle to avoid as much as possible unexpected over or under corrections. Now we move to the possible treatments of dystonia. As we said, optical treatment of ametropia is mandatory if an ametropia is present. It may be the only treatment in some cases. As all of us, by observing strabismus, I learned that time had every right in strabismology except for amblyopia. Lots of infantile esotropia modify or spontaneously resolve during infancy. This is, in the opinion of many strabismologists and in mine, a strong argument against early surgery. On the other hand, I think botulinum is a very good tool when you want to do something in early ages. Many studies have shown that 40 to 60% of injected cases won't need surgery, and 80% grow up with a low angle of strabismus until delayed surgery. Actually, these results are not totally explained. A possible neurological reset of the Vergence Tonus balance has been evoked when performed early enough, between 6 and 18 months. At last, what surgical means do we have to treat overactive muscle? Is innervational surgery possible? The aim would be to weaken such a muscle without modifying the balance in rest position. None of these techniques that I'm going to describe are perfect since we treat on muscles a brain dysfunction. Many studies compare them together, mainly on convergence excesses at near. Augmented recession is widely used, but exposed to consecutive overcorrection. Slanting of medial recti is proposed in high ACA ratio. It is easy to perform, but moderately effective. While splitting has been proposed by Bagolini, it reduces the torque vector by sagittalization of medial recti, reinserted laterally after splitting. I have no experience of this technique. Oliver Hurt reports a good efficiency and increasing effect with time and few revisions. Surgery of the arc of contact is a fascinating field of interest since the late 70s with Fadenoperation and recently recessed resect surgery on the same muscle. Fadenoperation, that I prefer to call posterior fixation, is a surgical procedure to weaken a rictus muscle, first described by Kuipers in 1974. Although the most efficient mean until now to treat overactive muscle, surgeons hesitate to use it in their everyday practice for different reasons. It is a weakening procedure that acts like a brake with no action in rest position, but an increasing effect in the direction of action of the muscle. Posterior fixation shortens the arc of contact and reduces the rotational force as soon as the globe rotates in its direction of action. It is all the more efficient when the globe rotates. Elsewhere, it fixates the pulley against the sclera and then induces a mechanical limitation of the movement. Kuiper insisted on the fact that during versions, posterior fixation increases innervation on the operated muscle, but also on its yoke muscle. It is better to perform it under the light of the microscope. There is a little learning curve, but posterior fixation of medial rectus is performed on a thick sclera, and it is not more difficult or dangerous than a large recession. Few specific tools are needed, as usual retina forceps and a curved caliper. Sutures are non-resorbable. I use a nylon 50 suture as it is much more biocompatible than a multi-fiber thread, and you can really see the difference if you have to come back on it. Spatulated needle allows to securely tunnelize the sclera. The original Fadenoperation is still used by lots of surgeons, but the bites in the muscle to perform the marginal anchorage have two major drawbacks. The first one is that it leads to fibrosis on the anterior part of the tendon. The second is the need to preplace a possible associated recession. I prefer the technique of posterior strapping or bridging as described by Kerry and Castiela. This technique is less aggressive to the muscle as there is no bite in the muscle, then no bleeding and very few scars. Elsewhere, recession may be performed after posterior fixation, which is much more easier. I describe in this short video the posterior strapping of a left eye medial rectus followed by a recession. This is the surgeon view. After fine dissection of the muscle, I measure the position of the anterior part of the pulley. Here the distance is 13 millimeters from scleral insertion of medial rectus. Then I make a scleral mark beside the muscle, and I pass the superior anchorage of the strapping. The needle is conducted deep enough, then parallel to the surface, then out. Beside medial rectus, the sclera is usually thick and perforation must not be feared. It is amazing to see that the pulley position is almost always at the same distance that the vorticus veins. That could be a scleral mark to place the faden. Then I pass the inferior scleral bite in the same way, and I just tie the knot beside the superior part of the strapping. I control the tension so that the muscle is flattened against the sclera, but not too much. At the end of the procedure, you can see that the muscle is perfectly safe of any bleeding and that the strapping is just beside the pulley. The recession is easily performed after the strapping, and the muscle slips spontaneously under it. Some surgeons blame on faden that the effect is unpredictable, and this is true when it is placed systematically at the same distance from scleral insertion of medial recti. You can see here 3 faden placed at 13 millimeters from insertion. The distance to the pulley is different in each case. This is important because if faden is placed too far, it is paralyzing, and too close, it is inefficient. I published a series of measurements of the pulley position of the right muscles, and it showed that if there is a mean position, it may vary dramatically from one case to another. Then I presented more stable results when faden was placed function of the pulley position. Some drawback underline the limits of the surgical technique without rejecting it because improvements are always possible. There is actually a little learning curve. The limitation of adduction may be troublesome in adults, but no children in my experience complained of diplopia in lateral gaze. This boy had a bilateral Fadenoperation as only treatment for 40 prism diopters, esotropia, and nystagmus. And you can see the slight limitation of adduction. The vanishing effect is probably the only limit of the technique. I observed it in 15% of my cases in the long term with recurring esotropia, but all cases that needed resurgery were easily treated simply by repositioning the faden. I presented in ESA a series of redo surgery on medial recti previously operated with posterior fixation. I believe it's not more difficult than coming back on any previously operated muscle, and it is possible to take it off or replace it, and even recess or anteriorize the muscle if necessary. I think the surgical tips I gave previously are important to ease possible redo surgery. Finally, the efficiency of posterior fixation has been studied mostly on convergence excess at near and stays the most efficient surgical mean in this situation. There are very few overcorrections. Personally, as I was convinced that purely tonic esotropia could be treated in the same way as convergence excesses at near, I published the results of a series of purely tonic esotropia treated with posterior fixation only, whatever the awakened angle. Long-term results was 75% of microtropia without correlation with preoperative angle, age, or ametropia. Given these positive results, I tried to apply them to surgery of partially tonic esotropia with a combination of recession and posterior fixation of medial recti tuned by the examination under anesthesia. The combination of recess resect surgery and Fadenoperation is efficient and known for a long time now. Classically, bimedial recession treats the minimal angle of esotropia measured on unilateral cover test, and posterior fixation is combined to treat possible convergence excess, fixation in adduction, or to dampen nystagmus. My personal approach was a bit different as I tuned surgery under anesthesia. If esotropia resolves, I only perform posterior fixation. If esotropia decreases, simply I perform posterior fixation and medial rectus recession tuned by the traction test. And at last, if esotropia is unchanged under anesthesia, I perform a bimedial recti recession tuned by traction test. Bilateral posterior strapping is performed when the angle decreases and may be the only procedure. Recession is performed when esotropia remains under anesthesia. It is decided eye by eye and equal to the amount of hypoelongation of the muscle in millimeters. This is an example with a 20 diopters esotropia at distance and 30 at near. If this esotropia total is straightened under anesthesia, I'll perform a bilateral posterior strapping, that's all. But by example, and for the same strabismus, if the right eye is straightened under anesthesia, but the left eye is still around 10 diopters ESO position, I'll perform a left medial rectus recession tuned function of elongation. Here it was 4 millimeter. As esotropia has decreased under anesthesia, there is a dystony and a bilateral posterior strapping is performed. I always perform it bilaterally by means of efficiency. We present during this meeting the results of a series of 130 consecutive cases of operated infantile esotropia in children with evaluation at 1 year and more than 5 years postoperatively. As you can see, 57 were purely tonic esotropia treated with posterior strapping alone. 38% decreased partially and had a combination of recession and faden, and only 5% were unchanged and treated with recession alone. Overall, 95% of esotropia decreased under anesthesia and had posterior fixation. At 1 year follow-up, we had 70% of good results. 8% were exo, most under 20 diopters, and 22% were esotropic, 5 over 20 diopters. At more than 5 years follow-up, as frequently in this type of series, only 60% of files could be analyzed. And we believe this has an impact on the results. 45% were microtropic, 5% were exo, none over 20 diopters, and almost 40% were ESO, but only 15% were exceeding 18 diopters. The main conclusion of our series are that the goal to decrease the rate of consecutive exo is reached with this approach. The number of secondary esotropia is quite high. It led us to be more severe on the measures performed under anesthesia and to place the faden 1 millimeter further than before, and early results have become better. Elsewhere, the increasing rate with time is real, but not so important and related to disinsertion of the faden from the sclera. We currently search for more permanent ways to fixate on the sclera. But note that these consecutive ESO are easily treated with good postoperative results. Given these encouraging results, I tried to look in other ways and was interested in this technique of resection and recession on the same muscle. It has been proposed in 1956 by Beatty to dampen nystagmus, and then by Alan Scott, who proposed it as an adjustable alternative to Fadenoperation in concomitant versions. Then various authors used it in convergence excess at near with encouraging results. This technique is a combination of more or less the same amount of resection and recession on the same muscle. Recession must be posterior enough to decrease efficiently the arc of contact. Similarly to Faden, it decreases the arc of contact of an overactive muscle. In Fadenoperation, the anterior part of the muscle is functionally suppressed. In this technique, it is removed. Also similar to Faden, the pulley is fixated near the sclera. And at last, this surgery removes the nerve palisade endings contained in the tendinous ending of the muscle, and this may induce a reorganization of the oculomotor balance through proprioceptive pathways. This is my technique of recession resection on a medial rectus. 8 mm of recession is a good compromise between efficiency and possibilities to return on the site for possible recurring surgery. As this technique was compared to Fadenoperation, it has been tried in convergent successes at NEAR with good results in various series. Then, for the same reasons, I compared its efficiency with Fadenoperation in purely tonic esotropia and presented the results in Helsinki in 19. The results are almost published. We showed a very good efficiency for both techniques with 91% microtropia in recess resect and 80% in the Faden group without statistical differences. Finally, recess resect on the same muscle seems efficient on any overacting muscle. It avoids a very posterior fixation, and it is possible to combine it with an adjustable suture or to shift the muscle. The drawbacks are related to the very large recession with questions about long-term and consequences in case of slippage or recurring surgery. In conclusion, I have always thought that it was important to go further and try to improve our results of treatments for the benefits of our patients. The idea to treat specifically each physiopathological mechanism leading to esotropia makes sense. By example, it led to a dramatic decrease of the number of operated infantile esotropia since optical correction was systematically prescribed and since we waited for esotropia to be stable during follow-up before indicating surgery. I hope I convinced you that the results of the examination under anesthesia of esotropia is an essential file. In my opinion, it should systematically complete the description of each operated case of esotropia, in the same way as the awaken angle, and may even lead to a specific classification. The provided information have direct surgical consequences on our surgical protocol. The surgical treatment of overactive muscles is fascinating, as we treat on muscles a brain anomaly. I hope I also convinced you that Fadenoperation may be enhanced by the way of few important tips, and of course, other means of treatment, such as recess resect on the same muscle, and probably why splitting have to be explored. As you all know, it is difficult in strabismology to compare long-term results of various surgical approaches. Sometimes, the short term may appear more important or satisfying. I believe some parts of strabismology escape to evidence-based medicine because so many elements influence the control of the gaze and the satisfaction of the patient. We are guided by evidence of efficiency, but also clinical observation, thinking, companionship, and experience. Although the results of all these works are just honorable, they follow a logic, they are promising, and may be improved. Obviously, it opened gates for further works. And I thank you very much and hope to see you soon.